Welcome, everybody. I'm Dr. Joshua Goldenberg. I'm the founder of Dr. Journal Club, and today I have the pleasure of interviewing Dr. Cynthia Long, who has just published a really excellent whole systems, pragmatic research trial on chiropractic. Came out in JAMA Open?
JAMA Network Open.
JAMA
It
Network
was the
Open.
inaugural issue, actually, of this. So it's open
Fantastic.
access, which is the greatest thing, right?
Really great, big study, and I can't wait for us to get into it. But Dr. Long, if you would be so kind, maybe introduce yourself a little bit to our audience. We do have a summary of this excellent study on Dr. Journal Club, but we are going to cover a little bit about it in this interview as well. So Dr. Long, tell us a little bit about your background and introduce yourself, if you will.
Okay, well, I am the Director of Research here at Palmer College of Chiropractic. I am the Director of the Office of Data Management and Biostatistics here at the Palmer Center for Chiropractic Research. My background is in biostatistics. I have a master's degree in statistics and a PhD in biostatistics. And so on this particular study, my role was director of the clinical trial coordinating center. So we handled all of the data, of course, but a lot of the trial and trial management aspects as well.
Wonderful. And so it was a rather large study, so I imagine there was quite a bit of that organizational skill that was needed.
Yeah. In fact, I mean, we do have anybody that's ever interested in just seeing what we went through to get this and two other studies that were funded with it. We have an article, protocol article on this study in the journal Trials. I think it came out in January of 2016. And it goes through getting all of the regulatory things going. It took, a good 2 years before we could launch one thing after another. And that gives a pretty good synopsis of those sort of trials and tribulations.
Yeah, absolutely. So tell us a little bit about the study for the folks that haven't had a chance to read it or see our other summary.
So this study is looking at, well, first of all, I should say that it is funded by the DoD. It was a congressionally mandated initiative that came out in the summer of 2010, and I think quite a few people responded to it. We were the ones that got the funding. And in the primary trial, we have two other trials, one that's still ongoing, but the primary trial was this large trial that we're talking about today, where we were looking at, so first of all, I should say, and it says in the paper that chiropractic is integrated into the military healthcare systems in the U.S. at more than half of them.
I was so surprised. I mean, pleasantly surprised, but and shocked. I had absolutely no idea. So this was an initiative coming out for our Canadian friends. This was coming out of the Department of Defense,
yes,
U.S. military. Okay, go ahead.
Yes, absolutely. And they're really trying to get a sense. The background of the paper describes that low back pain. We know what it is in society in general, but in the military, it's either the or one of the primary reasons for these are active duty military personnel seeking medical care and having disability that takes them or not being able to be at full strength or be able to work. So it's a huge issue for the military, of course, they want their active ready soldiers. And so we're looking at with folks with musculoskeletal low back pain, whether everybody got medical care, standard medical care, whatever it is, they're pretty similar among the three sites in our study, but whatever that standard medical care for low back pain is, and this was all kinds of low back pain, acute, subacute, or chronic, and then we looked at one group that had standard medical care plus they got referred to chiropractic care.
Gotcha.
And just looking, does that addition of chiropractic care to standard care for low back pain in the military settings, improve outcomes.
So you have okay, so you have an active duty personnel. They've got some low back pain. They present to the doctor on the base, and they say, "Hey, there's this study going on. We could either do convention. We could either continue to do what we're doing now, or we could do this. And I'm going to refer you to chiropractic, something like that."
Yes, yes. There was also general advertising. Some people referred. Came into the study through that, but everybody was screened by a medical physician for eligibility criteria.
And it was huge, right? Something like 750 patients or something like that?
We ended up with 750, 250 at each of 3 sites. So
wow.
Our sites were Pensacola, Florida. Most of the folks for that site are aviation training. They're young, they're students, they're there for like a 6-month rotation or whatever. San Diego Naval facility, and then Bethesda. Bethesda included Navy, Army. It's the National Military Health Center.
Got it. So basically they're getting their conventional care, and then some of them, I'm assuming about half or something, are randomized or quasi-randomized to also get chiropractic.
Right.
Okay, got it. And so and the intervention period. So is it? I remember the chiropractic arm was six weeks.
Well, everything was 6 weeks.
Everything was 6 weeks. Okay.
That doesn't mean that what you were referred to or prescribed in the medical arm might not have continued, of course, but the actual active treatment period for both groups was 6 weeks.
Got it. So
our primary outcome was at 6 weeks, and then we have 12-week follow-up as well.
Got it. Okay, excellent. So basically, is there any regimen as far as how many times they'd have to go see MDs or the DOs or the chiropractors, or is it just as it was prescribed, as it was normally practiced?
Well, yeah, as it was prescribed, we wanted everyone to get to the MD at least once. That happened at 2 of the sites. The other site had corpsmen doing the initial screen, and so not nearly as many of them made it to the MD. And that was a self-selection. For chiropractic, they could have anywhere up to 12 visits.
I see.
One thing that, this paper, one reason the military wants to know this too is they are super busy at their chiropractic clinics. They cannot, we had that issue. We had to find slots for the participants so they could be seeing the chiropractor. So, it's difficult to get in. And so, that's exactly, you can see in the paper, and we can talk about it in the results, just how, on average, how many visits we had, and they were different at the 3 sites.
Gotcha. So, there's a lot of things I liked about this paper, but one of the things that I was really excited about was it seemed to me that it allowed it to play out as it naturally would. You've already got chiropractic integrated in. I could certainly see in my mind's eye someone coming in, getting evaluated, and saying, "Hey, can I also go see the chiropractor?" And I'm sure that's happening all the time in the military, and so they needed some outcome data for what's already kind of in place, which I thought was...
No, that's exactly right. And that comes from both the patient saying, "I'd like to see the chiropractor," and physicians that have had working relationships with chiropractors and refer to them often. So, it comes a few different ways.
Awesome. So what did you find? What were the results?
So our results were that our primary outcomes were pain intensity and pain disability from, low back pain related. And so in both groups, across sites and overall, we found that there was both a statistically and clinically significant improvement, higher in the group that had the additional chiropractic care than in the usual medical care alone. Usual medical care had some improvements. Usual medical care plus the chiropractic care had more improvement.
Gotcha. And I love that there was a focus on not just something we talked about a lot on these videos, not just statistical significance, but differences that actually matter. So clinical
Yeah.
significance as
I mean,
well.
I'm a statistician, you know, you can make anything statistically significant. It doesn't necessarily matter, right? So it's
Right.
really important. And these were considered by current standards in the measures we use to be moderately of moderate strength in terms of clinical importance.
Yeah, I'm remembering 30% improvement or something that seems super reasonable.
That was a responder analysis where
Mm,
we saw similar results, but in terms of just I mean, everything was consistent in really all of the results.
great.
But we did a responder analysis and we did the actual outcomes. And in the outcomes, when you're, the variable without dichotomizing it or splitting it into two at all, we found that, we exceeded what they would consider the threshold for a moderate effect.
Nice. Okay, so you're seeing real effects. You're seeing effects that are meaningful to patients. Excellent. Anything that was like shocking or surprising to you guys about what you found, or were you pretty much expecting something like this?
It's pretty consistent with what we find in our smaller trials of chiropractic. The secondary outcomes included perceived improvement, satisfaction, which were both much higher in the group that also received additional chiropractic care. The medication use overall was less, this was patient self-reported, was less at the end of treatment for the group that had chiropractic care, but it wasn't statistically significant at any of the sites.
Mm-hmm.
And in addition, we have to remember these are healthy,
Right.
military ready participants, and so that shouldn't really surprise us. They're not on a whole lot of medications anyway. Very low prescriptions for opioids or taking
Yeah,
opioids.
I was curious about that because I was thinking, I would imagine, I don't know, but I would imagine, like the medications that one might get for low back pain, muscle relaxers, opioid painkillers, that might take people out of their ability to do their job in the military, and there might be, rules and regulations about, well, if you're on these meds, you can't do your job. And so I wondered if, well, maybe that's just keeping the prescriptions down in general in this population.
Well, I can only speak for our participants, and they
Mm-hmm.
definitely were done. Lots of NSAIDs,
Mm-hmm.
in particular, but really not much in the way of prescription medication. I kind of hear through the grapevine that maybe that's not consistent for all sites and all.
Mm.
These are low back pain too, right?
Right.
And
Right.
so, at least in the military, this is what we saw.
Interesting. So, this is awesome. And again, for the listeners, we'll link to the proper review that we did, and the paper too. It's open access, like Dr.
Yeah.
Long said, and so you can access it. We'll have a link to that too. But if you have a moment, I'm really curious about, whole systems design in general, and also, pragmatic comparative effectiveness trial. I mean, it's not a design that many people are familiar with. But I feel like it's an important one. Would you speak a little bit to the choice of using that and what that even means for our listeners?
Yeah, absolutely. So, in particular, okay, chiropractic, the main therapeutic tool or whatever is spinal manipulation. Spinal manipulative therapy is what it's usually referred to as. However, chiropractic is a package, and anything that you would think of would make sense because it's mostly musculoskeletal pain patients that come to chiropractors. So therapeutic exercise, both in the office and at home are huge in that. And then self-care is huge in that. And then all kinds of other, you could see there's a e-table, a supplemental e-table that talks about what was actually used. And you can see that each site, they sort of had their different packages, but they always use something other than just spinal manipulation. That is the way chiropractic is practiced. And to be quite frank, most of the studies, there are really few pragmatic studies out there published, and even if they're there, they're fairly tightly controlled, so they're not very big on the pragmatic scale, if you may. And you know, with typical chiropractic, or with most of the studies that have been done, it's explanatory studies looking for efficacy. And so they're trying to tease everything else out. So we've done a lot of efficacy studies here at the center. And, you know, what happens, chiropractors always struggle with it because it's not what they do in typical practice. It's spinal manipulation. It's usually we do a lot of low back pain research, and it's usually just sort of isolated to the low back in certain regions. And the way we've gotten around, so we do something is we give everyone in the study the same recommendations for either self-care or, you know, just so they have an idea a little bit about their back pain. And so everybody gets the same thing. But that is not the way it's practiced. Now, of course, you know, research is an evolution, right? And certainly early on, there's a lot of chiropractic users. You know, we're going backwards. It's not going to bench to bedside and beyond. It's been delivered. You know, we have high use of chiropractic, especially with people with low back pain, right? And so, you know, there was the need to have some of this efficacy research, and that's important. But that's pretty much all of the studies that are out there. Some of them are sham controlled, some of them have other sort of inert controls, some of them have comparative effectiveness sort of controls, even though they're more of an efficacy sort of study because they're tightly controlled and not really very pragmatic. But they're really trying to isolate spinal manipulation. So this, we really backed up and make sure that we're talking about chiropractic care as it is delivered, right?
Yes.
And so spinal manipulation, that's the primary tool, but all of these other things, which, you know, we're probably the first group that's really looked at the whole package as it's delivered. So it's time for comparative effectiveness research. It used to be that a lot of funding wanted efficacy research, and that actually limited quite a bit. We're having a huge turn, in particular with respect to the opioid crisis and healthcare expenditures and all of the things that are happening in healthcare. There's a big turn about, wait a minute, we need to be studying pragmatic studies and effectiveness to look at changing medical systems and healthcare systems, whether it's in the military or somewhere else. And so, I mean, that's exciting. You know, that's how we got the opportunity to do this. And now we're seeing at NIH some big collaboratories on pain research, of which we're part of, that I can talk about sort of at the end if you want. That are really about, let's do best practices and pragmatic studies. Let's really try to study the package. And so you're not going to see placebos or shams or anything else. Not to mention, as anybody that does any kind of physical medicine knows, shams are very difficult because they're probably not inert, right?
Exactly.
Laying on of hands is really difficult. So it's always been difficult to do those kinds of trials in any kind of manual therapy, chiropractic included.
It makes sense to me, and I know you argued this in the paper too, is that two things. One is that, look, that we've already done these sham control studies. We know that there's something to these, at least the manipulation part, right? The adjustments. And then also, it's already being practiced this way. So let's measure it, which makes a lot of sense to me. Couple questions on that. So one is, so forgive me, I'm not a chiropractor. A lot of my friends
I'm not a chiropractor either.
We'll have to get some listeners to call in, but my understanding is that there tends to be sort of the same with naturopathic. There's a spectrum, and that some chiropractors are pretty much straight chiropractic manipulation, and then others kind of mix in other therapies too very often. And so I guess my question would be, is there any reason to believe that these centers were more one way than the other, or was it like a random mix of practitioners and we're kind of getting an average? Or like, if we're trying to translate this to real life, do we say, well, go to the mixer chiropractors, or go to the ones that are just doing manipulation, or what do you think about that?
I think that straight versus mixers in sort of, again, I'm not a chiropractor, but I've been in this environment for quite a long time. I think that is much less. Certainly that's the way it started when I came 25 years ago, right? It's very much that way. That is in modern day medicine and modern day healthcare. That's not so much. You might have some solo practitioners out there, because a lot of practitioners are in their own little office. You might have some that are still might be called straight, right? But the majority, especially once they get out of school and they get with patients, they're going to use any tool that they can that's really part of a bigger box. And I think that, don't quote me on this because I don't have any data for you right now, but I think that if you talk to the average chiropractor, they'd be saying, I have a whole bunch of tools, and I use them as adequate.
Makes sense to me. So did you find that in your centers where all sorts of different things were being recommended?
Yes, and we have, there is a supplemental set of tables that are online. They're available. They don't come with the paper, so you have to click under the supplemental tables. And we said, we asked, the funny thing is that they're all different, but they all have multiple sets. Therapeutic exercise is used pretty much uniformly. I'm looking here, one site used probably everything that you could imagine. We had a list, so there could have been other things, but these are the most common things. Hot and cold packs, traction, stimulation, ultrasound, infrared therapy, laser therapy, different kinds of therapeutic exercise, one for strength and flexibility, one for function, other manual therapies, and home management training, and they all use some combination of those.
Wonderful. So the idea being you go to chiropractic care, period, and that it will probably involve a mix. And because your group was so large, you can try to kind of average those effects out to the whole system of chiropractic as it's prescribed and as is practiced in real life, which makes a lot of sense to me.
Certainly in the military. I don't think you're going to find anyone in the military that's not using their package.
That's so interesting to me. I just think that's really cool.
There has been, I don't have that paper out here, but if you Google, you can find a couple papers. I think Christine Gertz was on these. I think she led these efforts of just trying. We have this for both military medicine, and we have it in the VA as well. It's just, what are the chiropractors like? Why are they there? What are they practicing? And so those are very interesting for people that want to have a better sense of, at least in these multidisciplinary environments, how chiropractors are practicing.
Fascinating, just fascinating. So we did have some questions from the audience, if you will. The people were curious. A lot of people were curious about, what is the new and exciting research coming out of the chiropractic world? I mean, you're there at Palmer. It's been a major center for chiropractic research. I mean, you just knocked out this excellent, massive study. What's next on the docket? What do you guys have planned?
Well, what we've been working on, we have funding from the NIH, two different studies. One is to get into the VA, to do studies in the VA. And so we are just, we have a pilot study that has 38 out of 40 recruited. We think by next week we will be full. Just looking at, because chiropractic is also integrated very well into VA, into a lot of VA centers. And, that started in 2004, I believe. And I keep saying Anthony Lisi is kind of the chief. He's a DC, and he's sort of the chief head of VA chiropractic systems. And he's got a lot of research out there, again, for anyone that wants to go look at what's been happening in terms of chiropractic in the VA. But of course, the thing about the military settings is that these are healthy, really healthy people. And, we don't, in most of our studies, we don't see really healthy people. These people are fit. They are mentally fit, combat ready, right? Well, the VA, as I think anybody that watches knows, that we've got a huge crisis in VA. Treating, veterans where there is a lot of mental health comorbidities, and rightfully so, right? And so this particular pilot study was looking at treating people with what we find is everyone in our study, except for I think two, have anxiety and or depression and or PTSD.
Wow.
And it's really looking at this any kind of pilot. Can we get them? Can we recruit them? Can we get them coming to the kind of the prescribed number of visits? This is another pragmatic study. Can we work with the VA chiropractors and in the chiropractic setting? This is somewhat in the military too. You have to have a referral to get into the chiropractor. We work with those PCPs and those the nurses and the nurse case managers, and to set all of that up, saying, can we get people in? Will they? And this, of course, is near and dear to my heart. For both the military study and for really all the research we're doing now and in the VA, we use electronic data capture. So everything's coming via a web link to participants they initially do this in the office when they're getting consented for the baseline, but then we have lots of outcomes being collected over time, and how can we best get the highest? We did very well with the military. We'll see how we're doing with the veterans. We've been monitoring that through this about a 6-month pilot study that took about a year to design and get through regulatory things and be able to conduct. But the exciting thing is that almost exactly a year ago, we got funded as part of the NIH DoD VA Pain Management Collaboratory. We have NIH funding for this. And it's a 2-year planning period for a large pragmatic studies or chronic pain. It has to be chronic pain, which is mostly what we see in our studies anyway, with the exception of one site in this study that we talked about here in the military. But it's chronic pain. We're looking at chronic low back pain because that's what that's what we do. And this is on we have a 2-year planning year to proceed, and we're 1 year in to get all the protocols, all the regulatory, which they found out because it's so hard to get through all of that they've learned. You need a 2-year planning period for these kinds of studies. And so we are in our first year. We're trying to get the protocol done by the end of the calendar year. That has to be submitted, and then we have to go through all kinds of things to get the last 4 years of funding. We fully anticipate that happening to do a 4-year pragmatic study. And ours is a different design than we did before, and it's something that really we need in general, but in particular, VA, it is hard to get in. You get your visits, you don't ever get extra visits, you don't get long-term care, and we're talking about chronic pain patients mostly with mental health comorbidities, right? And so this study has 2 phases. The first phase is looking at like a low dose, sort of what you get on average in the VA now, which is quite a bit lower than the little bit of research that has been done on this subject, as well as what's really done in practice.
Oh, interesting.
So sort of a low dose versus a high dose. So sort of an average of 5 visits with the chiropractor over a 10-week period of time, or an average of, I think, 12. 10 or 12 over a 10-week period.
Got it.
So the first question is really, okay, everybody thinks for chronic low back pain patients, we really need more visits. Is that the case? And if so, that tells policymakers at VA.
So that's nice. I mean, that just does tell perfectly into policy recommendations. Be like,
this is what it's designed to do. Is exactly
nice.
The second phase is to take any of those that are interested in potential long-term care, sort of what sometimes called maintenance. We're really calling it a chronic pain management, longer-term management, where they have a scheduled visit with their chiropractor once a month for the rest of the year, and whatever other usual care they get. Versus a group that is not scheduled. That doesn't mean they won't end up at the chiropractor, but they're not scheduled to come in. And you can imagine that we think that they're going to be managed better and really have less healthcare utilization,
right?
If they have that opportunity, and that is not even a possibility in the VA right now. It's the resources are not there.
But if you could show a good, I'm sure you're doing cost analysis as well.
Yes. So the primary are looking at the patient's self-reported outcomes, both at that initial and then after a year. But we have partners. So let me tell you, so we're at Iowa City VA, we're at Minneapolis VA, we're at Connecticut VA, and we're at West LA
Hmm.
VA, where they all have chiropractic clinics, at least one, if not multiple. And so we have academic partners from Yale who are doing all of our EHR data extraction, which are going to do it's a little harder to do cost analysis in the VA because of the payment, but we will be doing health utilization, which then can be translated to costing
Gotcha.
one way or another. We have partners at University of Iowa. We have partners at Dartmouth. So, as well as a whole bunch of people here at the Palmer Center for Chiropractic Research. So it's a very exciting study. It's going to be a very large study, and you need two years of planning. Let me tell you that. And
Oh, I bet at least. Oh man.
we were really fortunate because we're part of a big collaboratory as well, doing these pilot studies in VA or DoD. Ours was in VA, and because we had three aims, and our first aim was to just start doing qualitative research, interviews, stakeholders, and try to get a grasp of what's going to take to get how do they feel about chiropractic, refer as well as research in the chiropractic or in the VA arena. Then we developed, and this is published this last year. We I think Anthony Lisi is the lead author on this as well. We used a Delphi panel to develop a clinical care pathway in the VA, in particular looking at mental health comorbidities and how that pathway should go. And so we have that will be used in this big study. But so the pilot came at the very end, right? So we were writing the grant for the study, the big study, and we decided with, of course, NIH supporting us in doing this, it kind of revising our pilot a little to be really truly a pilot study for the big study. So we're getting all kinds of, I will be spending the next 2 months, I think, pretty much, given we're almost closing enrollment. We have 10 weeks of data collection and looking at that data, and really, we've been doing it as we go, but really trying to say, how can this inform the protocol for this big study at Foresight? So this has been super, super exciting.
Yeah. Oh, well, you can tell just listening to you. I mean, you're really getting jazzed about it. And it sounds like, my goodness, it's so involved, and there's research even just leading up to the next research to the big study. So really, really well done. It's super exciting. Congratulations on the one that was published that we just chatted about. I look forward to seeing the results of the next one and all of your other future endeavors.
Great. So should I tell you about one other thing we have now?
Sure, yeah.
So this is just 1 year in. We've been kind of in a planning year, but we have the Palmer Chiropractic Foundation has funded the interdisciplinary network for chiropractic research, and so we're partnering with highly intensive research organizations. And right now we have the Yale Center for Biomedical, or not biomedical, it's medical informatics. Where they can pull all of the EHR data that we need for a lot of questions, right? And the Osher Center for Integrative Medicine at Harvard and Brigham and Young Hospital. And so we have two or three studies that were sort of started in the first year. Now we're in the second year. We've got a bunch of other studies, and that is very exciting as too. Whenever we collaborate on everything we do, and I have to say, for people out there, if you're going to do research, you need to find collaborators that can bring the tools that you need to do this good research, and that is super exciting. No results to give you yet, but talk to us in a year or two, and we'll be happy to talk about what we're doing.
We certainly will. Well, thank you again. Congratulations, and thanks for your time today.
Happy to do it. Thanks.